Okay, we're back to it. Kinesiology 230, chapter 20, presentation number 3. We're still talking about cardiovascular or respiratory conditions. Now, specifically in presentation 3, we're talking about the cerebrovascular accident and peripheral artery disease. Cerebrovascular accident, you'll see a stroke. So we're just basically building upon the three main things we saw at the start of the presentations here, where we had MI, stroke, and peripheral artery disease. So to that end, let's get going. Within a stroke itself, they have the classification of this as cerebrovascular accident, or CVA. It's a brain injury caused when blood flow to an area of the brain is cut off by either a blood clot or bleed due to ruptured blood vessels. It cause any itself, and you can have loss of cognitive function, challenge in communication, or many times a person is having a stroke. You look at their face, you have to stick tongue out. When they talk, they strain on one side, as the face is drooping on one side. It just depends where the stroke happens and where the blood clot happens. But some of the guidelines that they have here, in terms of when you look at this, you might have these simple tasks that we all do, but if you have somebody who loses some motor function, they lose some motor function in the arm, the leg, the face, or the mouth, here in understanding, you'll have cases where predominantly this is a hemisphere type conversation here, where if the stroke is on one side of the body, it'll affect the opposite side. So if I have a stroke on the left side of my brain, left hemisphere of my brain, it'll affect the right side of my body and vice versa. So the point you have here is you have to be able to first recognize these signs and symptoms if you're working with somebody who happens to have a stroke at the time you're working with them. But when you get into actually working with people, you have some benefits to be gained by actually working out. And they recommend that the workout should be 3 to 5 per week to 60 sessions, roughly about 40 to 70 of VO2, 11 to 14 of that scale as opposed to the 0 to 10. And so they're outlined here, and I would take a moment just to kind of get familiar with these. But it's a matter of, and they note here, slow and judicious evaluation of the client for starting loads. And I would say there's validity to that. You have clients who perhaps lost motor function, and they've gone through a rehab process, no doubt. But that rehab process will be very clinical, and sure, they're trying to replicate some ADLs, no doubt about it. But here you come into the equation, and you're going to hand your client some dumbbells and ask them to work out, ask them to lay down on a bench, ask them to move their body and change their body position, and they may have struggled with that. So part of the actual training itself for people who are stroke survivors, if you want to say it like that, for those individuals, it many times comes down to not even around. It's about being able just to move. With peripheral artery disease, it's like an aching or cramping in one of the more calves, thighs, or buttocks. So if you were to drop down and take a knee, and you fold your knee correctly and block off the blood flow to the lower extremities, it's very much like angina for the heart, but it's more in the muscles of the extremities. And oftentimes you'll have people say, oh my, I've angina of my calf, oh my gosh. But it's normally equated with the heart. When people say angina and they say claudication, that's equated with muscles in the lower extremities. Now, it's a case where there's usually a triggering event. So for example, they note here, like somebody is walking or climbing stairs. So you can just imagine the increased workloads that one has when doing those activities. But what happens is you have people who might look totally fine, and as they're just going about their day, they're totally fine. But as soon as you ask them to do some lower extremity work, walking upstairs, stepping up on a box, whatever it may be, bending their knee to do a squat or a lunge, it ends up being a case where they have a blockage that causes the claudication. So you have a seclusion that blocks off blood flow to the lower extremity, and the lower extremity cannot get nourished with blood that has oxygen in it, and so this occlusion causes that pain. Now, it's usually temporary, and it's something where a person can stand back up, extend their leg, or the blood flow to happen once again. But I will say this, they have varying degrees, and they talk about these different stages, and there's 4 main stages of the classification scale, and they're pretty straightforward, but it's a strongly correlated risk for MI and stroke. So individuals with PAD, peripheral artery disease, may therefore also present with these other conditions. So you got to understand that these individuals are not a simple case. It's usually a more complex case in terms of what they bring to the table if they have some type of peripheral artery disease or recently had an MI or a stroke. So here you go with these scales. And if you look at this, on the left-hand side, you have the Fontaine scale, and then over here you have the Rutherford scale. And you have stage 1, 2, 3, 4, and over here it's grade 0, 1, 1, 1, 1, 2, 3, 3. And then they go category 1 through 6. So there is or are 2 different classifications, but when you look at this, no mild claudication, soreness, achiness in the lower extremities after 200 meters. And what you notice here is there's a little bit of a differentiation in between 2A and 2B because of a distance required, 200 meters. They really don't define that over here in the Rutherford scale. But you have ischemic rest pain, mostly in the feet, ischemic rest pain. They don't define where. They note over here in stage 4, lower limb or foot ulcerations, gangrenous, meaning gangrene is gangrenous, or necrosis, dying of tissue. So you could have people who perhaps are diabetic and they have circulatory issues. Many times their toes become necrotic. The tissue dies from lack of servicing of blood flow to the actual toes themselves, and you see people who have to have amputations as a result. So with this, on the Fontaine scale, they denote in level 4, stage 4, lower limb or foot ulcerations, gangrene, or necrosis. Over here, you have minor tissue loss, major tissue loss when you get to 6. I got to tell you, if somebody's cutting off my pinky toe, that's not a minor tissue loss. I'm viewing that as major. But anytime you have to cut off body parts, it's a major tissue loss for me. But just kind of yourself to these. There will be a little bit of reflection to these, but just take a moment to review and compare and contrast these for later reference. Now, exercise guidelines for clients with peripheral artery disease. There's a few, tricky quiz questions I got to tell you, and they're a little bit of a challenge. So depending upon the severity of the leg symptoms, individuals with IC may be available to walk continuously for only a limited time, 1 to 2 minutes. All right. Other forms of exercise that can benefit the health of the individual with peripheral artery disease, with or without claudication symptoms, include home-based walking programs, resistance training, flexibility exercise using the same general FIT principles, frequency, intensity, time training, as other cardiovascular disease. So are we talking about with symptoms? Are we talking without symptoms? Depending on the severity of their leg symptoms, health with their symptoms. Oh my goodness. It's like dizzying. Is it with or without? So use caution when you read through some of the questions specific to peripheral artery disease, and I'll ask you to reflect back to this part of the book because it can be confusing in terms of what they're asking and the answer that they want. You may have to just sit down and parse out the questions side by side with these passages in the presentation because I think it's a little too tricky. It doesn't need to be that tricky, to be quite honest. But what they note here is 6 to 8 resistance exercises targeting all major muscle groups, but focusing more on large lower limb musculature if time is limited. And I know there's a question regarding that. Perform twice a week on non-consecutive days with intensities of 60 to 80 of 1 rep max recommended. So if you look at this, they're talking about 2 main things here, one of which is a cardiovascular side, one of which is a strength training side. And the more definite answer, the one it's easier to see, is specific to the strength training side. The 2 that they have up here regarding cardiovascular is absolutely more tricky, if I can say it like that. So with that, guys, I'm going to break off from this, go to the next presentation, and moving on.